Assalamu alaikum. I'm Dr. Maham Dilshad, and I welcome you back as we begin the second session of today's conference. It's a pleasure to introduce Dr. Syed Ali Rukh Peerzada, who is currently serving as Assistant Professor at Bahawalpur Victoria Hospital. Dr. Peerzada holds FCPS qualifications in both medicine and rheumatology, reflecting his strong academic foundation and specialized expertise in the field. He has played a pivotal role in establishing a rheumatology unit at his institution, which is a significant contribution towards improving access to specialized care in the region. In addition to his clinical services, he is actively involved in teaching and mentoring, contributing to the training of future healthcare professionals. His commitment to patient care and academic excellence continues to make a meaningful impact on the management of rheumatic diseases and the advancement of rheumatology services. We're honored to have Dr. Peerzada with us today to serve as moderator for the panel discussion on the role of glucocorticoids in autoimmune nephritis. Please welcome Dr. Peerzada to the stage.
Thank you very much for this kind introduction. Thank you. Good morning, everyone, and Assalamu alaikum. Welcome to this focused panel discussion on a topic that continues to challenge both evidence and practice. The role of glucocorticoids versus reduced or no glucocorticoids in autoimmune vasculitis, particularly ANCA-associated and lupus vasculitis with kidney involvement. As you know, over the past few years, all the guidelines, international guidelines, including ULAR, ACR, BSR, and KDIGO, they are progressively moving towards the lowest possible dose of the glucocorticoids in treatment of the renal involvement especially. This was driven by the landmark study PAXI-VAS and low-VAS trial. But the question we face today is, can we truly implement these recommendations in real-world settings like Pakistan, where infection burden is quite high? Access to biologics is inconsistent, and cost constraints influence the decision making. Monitoring facilities are also very scanty. So today's discussion is not just about what the guidelines say, but what is practical, safe, and feasible in our context. To explore this, we have an excellent panel of nephrologists, rheumatologists, who bring both evidence and experience to the table. So allow me to introduce and call our panelists to the stage for this exciting session, inshallah. It is a great honor for me to introduce the distinguished rheumatologist, academician, researcher of international repute. He is serving as the head of the Department of Rheumatology at Institute of the Rheumatic Diseases, Central Park Medical College, Lahore, and is currently president of Pakistan Society for Rheumatology. His extensive qualification and vast experience reflect his deep commitment to excellence in both clinical practice and academics. He has represented Pakistan on numerous national and international platforms and has been esteemed speaker at leading conferences like APLAR and ULAR, contributing significantly to the global rheumatology community. With great respect and admiration, I invite Professor Dr. Muhammad Ahmed Saeed Saab to come on the stage and take his seat. Thank you, sir. Our first panelist from the nephrology is Professor Dr. Hafiz Ijaz Ahmed. He is a distinguished nephrologist and educator, currently working as head of the nephrology at Aleem Medical and Gulab Devi Hospital, Lahore. Professor Dr. Hafiz Saab is the founder of the Department of Nephrology at Allama Iqbal Medical College, where his contributions have played a pivotal role in establishing and advancing the specialty. He has also served as the Dean of Nephrology at PKLI, demonstrating exemplary leadership and commitment to excellence. With his valuable clinical and academic experience across renowned institutions of the United Kingdom and US, he brings a wealth of international exposure and expertise to his work. His dedication to patient care, teaching, and the development of nephrology services have earned him great respect among colleagues and students. With great respect and admiration, I invite Professor Dr. Hafiz Ijaz to kindly come to the stage. Our second panelist from the Rheumatology Board is Professor Dr. Sumaira Farman. It is a great honor for me to introduce her. She is a highly esteemed and accomplished figure in the field of rheumatology. She is widely recognized for her remarkable expertise, particularly in pediatric rheumatology, where her contributions have been truly impactful. As the head of the Department of National Hospital and Medical Center, Lahore, she has demonstrated exceptional leadership, clinical excellence, and dedication to advancing the field. With great respect and admiration, please come to the stage. Thank you, ma'am. Our second panelist from the Nephrology Board is Professor Dr. Ibadur Rahman. It is a great honor for me, again, to invite Professor Dr. Ibadur Rahman. He is a distinguished name in the field of nephrology and a respected academic leader. He is currently serving as the head of the department at Aleemuddin Medical College and PGMI Lahore. With his vast clinical experience, dedication to teaching, and contribution to patient care, Dr. Ibadur Rahman contributes to inspire both the colleagues and students. Please, sir, Dr. Ibadur Rahman, come to the stage and take your seat. Oh, thank you. Sir, Dr. Tafazul, it is a great honor for me. Yes, sir. It is a great honor for me to invite our esteemed supervisor, Professor Dr. Tafazul Haq Mahmood, a renowned figure in the field of rheumatology in Pakistan. He is widely respected for his exceptional clinical expertise, academic excellence, and remarkable contribution to the training of the future rheumatologist. Throughout his distinguished career, he has mentored and inspired numerous students and professionals, shaping the future of rheumatology in our country. With great respect and admiration, I invite Professor Dr. Tafazul to please come to the stage, please. And our last panelist from the Nephrology Board, Dr. Professor Mateen Sahab. Professor Dr. Mateen Ahmed is heading the unit of nephrology at Sheikh Zayed Hospital, Lahore. His extensive qualification and vast experience reflect his deep commitment to the excellence, both clinical practice and academics. Sir, I request you to please join us on the stage as nephrology panelist. Sir, before I start, there are some ground rules for the panel. Before we begin, a few quick ground rules. I will direct each question alternately to a nephrologist or a rheumatologist to ensure balanced perspective. Each person response should be around 2 to 3 minutes, so we can cover multiple aspects of the topic. Panelists are encouraged to challenge each other respectfully, especially where specialties differ. Wherever possible, please anchor the responses in international guidelines and personal clinical experiences in Pakistan. Audience questions will be taken toward the end of the session, if time permits. So let's start. Please share my slides. First of all, I will share with you a clinical scenario of 40-year-old male, previously healthy, presented with 6 months history of the long-standing nasal obstruction. So this is a clinical scenario. 40-year-old male, previously healthy, presented to 6 months of the history, long-standing history of the nasal obstruction, recurrent nasal crusting, blood discharge from the nose, and sinus pain. He was initially treated as chronic sinusitis with multiple courses of the antibiotics and nasal steroids with only partial relief. 2 months later, he developed new symptoms like fatigue, low-grade fever, arthralgias, and significant weight loss of 5 kg. His examination revealed high blood pressure of 159 by 105 millimeter of mercury. Previously, he was not a known case of the hypertension. And there was pedal edema and periorbital puffiness with a saddle nose deformity as well. A few investigations were carried out, and urine report showed us +2 proteinuria, numerous RBCs, and 20 WBCs per high power field. Serum creatinine was raised, it was 2.8, and C-NCA test was 97 against the normal of the 2. So this is a clinical scenario of 40 years male who was having the chronic rhinosinusitis, and later on involvement of the rising trend of the creatinine with the history of the periorbital puffiness and pedal edema, rising blood pressure as well. So this is a case scenario. So my first question will be with Dr. Hafiz Ijaz Ahmed Saab. Please, sir, this is a question to you. In this patient who is presenting to us with sino-nasal symptoms and rapidly rising creatinine, which is suggestive of ANCA-associated vasculitis, what is the recommended diagnostic approach, including the role of C-NCA testing and later on renal biopsy?
Bismillahirrahmanirrahim. This patient with these symptoms which he has presented going on for a few months, and now laboratory investigations indicate significant renal dysfunction, proteinuria, and microhematuria, is highly indicative of ANCA-associated vasculitis, presenting with upper respiratory tract as well as kidney dysfunction. So from renal point of view, this is a patient who is having an organ at threat ANCA vasculitis, and we should proceed because all the necessary investigations are already available, and we should plan a renal biopsy that is indicative of which will show us the severity of the disease, chronicity, and how we are doing. But we will not wait for the kidney biopsy results to start the medicines. With this background of advancing renal dysfunction, symptomatology for more than 6 months, having hypertension, we should go according to the guidelines and start him on treatment.
Okay, sir, what is the role of the MPO and PR3 ANCA test in this particular patient?
Both these tests are very pivotal in deciding our patient whether he has got an ANCA-associated vasculitis or not, because these are the 2 tests which will confirm the association of vasculitis. So as we already have results with us, we will proceed for it.
Okay, sir. Thank you so much, sir. Sir, I pass this question to Professor Dr. Tafazzul Saab. Sir, kindly share your views point. So it's not. No, sir.
Yeah.
Mike.
Thank you so much. First of all, I would like to tell the audience that what is PR3 and what is MPO and what happens when we do suspect ANCA-associated vasculitis and what is actually going on. Because without that background, one cannot develop a treatment management approach. Both proteinase 3 and myeloperoxygenase are, as you know, cytoplasmic antigens which are present inside the neutrophils. And these, because of the chronic inflammation, as in this patient, there is something called MALT, which is mucosal associated lymphoid tissue. So from there, and some genetic factors which are also there, some environmental factors also there. So all of this leads to the activation of interferon gamma and alpha, and they prime these antigens, and they come to the surface of from the cytoplasm, they come to the cell. And then there is a term which is called extracellular trapping. So they come out on the surface, and these primed PR3 and MPO are then attacked by the complement 5A activated ANCA antibodies, which are produced by the B cell primed plasma cells, and it leads to the inflammation as well as the widespread nature of the disease that AAV patients suffer from. So with this background of knowledge, it is now easier for us to find these antibodies testing important. But this antibody testing alone is not important. The history which is presented in front of you before that, which is the sinonasal disease involvement, as well as the, urine complete, as Hafiz has said, the urine complete examination, which is a very simple test with RBCs in it, or RBC casts, and rapidly rising creatinine, as it has already been mentioned, blood pressure, and so on and so forth. Now, there is very little doubt that the disease is advancing rapidly and is probably associated with PR3, because this antigen, this ANCA, PR3 ANCA is mostly associated with a rapidly progressive disease. So, but that ANCA alone is not important. KDIGO and all other guidelines, they strongly recommend that the renal biopsy should be performed. But as Hafiz said, the nature of the disease does not allow us to perform, sometimes not wait for the results, and sometimes the patient does not agree to the biopsy at all. So we will start the treatment.
Okay, sir. Thank you, sir. We have taken your perspective. Sir, my next question is about renal biopsy. What is the role of the biopsy? Should treatment ever be delayed, as sir has told us? Already guidelines say you should treat the patient, not waiting for the biopsy. But sir, I want to know what is the perspective of the nephrologist. Do you start the treatment without the biopsy, or you wait for the biopsy?
Bismillahirrahmanirrahim. Thank you, Dr. Ali. It's a very, very interesting question. We face day to day such kind of scenarios in the management of vasculitis, ANCA associated. As you have mentioned in your clinical scenario, patient not only have the upper respiratory tract in symptom, as well as he has involved the kidneys in the form of pyuria, RBC cast, and renal function with the low GFR and very high ANCA levels. So, because we have to start, because it has involved the multiple systems, not only the respiratory tract, along with that the kidneys. Definitely, to save to save the system, we should have started the treatment, definitive treatment in the form of immunosuppression, glucocorticoid, and the other steroid-sparing drugs. Along with that, we should proceed for the renal biopsy because that is very important for the activity and chronicity indices and the long-term management of the disease. And definitely, and because according to the KDOKI guidelines, they have, if we go for the renal biopsies, there are certain 3 or 4 type of class. Focal class, in which focal glomeruli are involved. There's crescentic class, and there is a mixed class as well. And so, if we go for the renal biopsy, and we have the crescentic glomerular nephritis that have involved more than 50% glomeruli, we have to do and initiate the immunosuppression in the form of steroids and rituximab or cyclophosphamide, along with sometimes plasma exchanges as well. So looking forward the chronicity, that can we in the future, if we treat the patient, we have remission, partial remission, or the complete remission. So we should proceed with the renal biopsy and start the initiation of the immunosuppression for the diagnosis and the management along with that.
So your point is we should not wait for the biopsy, right? We should start the treatment, and arrangement should be done for the renal biopsy.
Because patients not only have only the active cause in the form of pyuria, WBCs, he has deranged renal function.
Yes.
The GFR is less than 45 ml. Because it is recommended according to the guidelines if the serum creatinine is more than 3 or 3.5.
Sir, we just want to know what is your practice and how do you deal with such kind of the patients while you are doing the round in the wards or where I am working in my department, we have rituximab freely available. So I start with the immunosuppression with the methylprednisolone and start the rituximab. Sometime, if it is not available or any other thing, if he has any active viral hepatitis, any other contraindication, then I can switch over on the cyclophosphamide. And sometimes I have to restart even if there are so many high titers of these ANCA, and the resistant GFR, it's not improving. Sometimes I started the plasma exchanges as well for in such cases, but not for all, in some cases, in my practice as well. And the same in the KDICO recent guidelines, they also have recommended. One thing I will just want to highlight it, we have to go for the serum IgG levels, because if currently I have one patient with ANCA vasculitis. He had 2 cycles of remissions and relapses. Now, I did 2 times renal biopsies, and he responded to that. But he presented after second course of rituximab with he has acinobacters. So, because we have this, it affects the immunomodulator system, and we should have the IgG levels that should be in the baseline before the treatment, especially if we start the rituximab. Okay, sir.
Thank you.
Thank you very much, sir. Sir, one question from
Can I respond
Madam,
to
please.
this?
Please, you want to add?
So basically, take home message एक तो ये है कि ज़रूरी नहीं होता कि आपके ANCA antibodies positive हों. So you have ANCA negative ANCA vasculitis also. You do not depend on that just for diagnosis. If there is enough clinical suspicion. Of course, if patient comes in this situation, you do not wait. You have to make sure you do the workup, rule out any other infection that may be present, because unfortunately, आपको पता है कि they are more prone to infections as well. If there is no infection, this patient has to be pulsed with IV methylprednisolone, monitoring the blood pressure and blood glucose. If possible, biopsy as soon as possible. और renal biopsy की ज़रूरत आपको बहुत 2-3 चीज़ों के लिए चाहिए. Of course, what is the activity of disease? What is the type of disease? Is it something that is necrotizing GN जिसके अंदर आपको शायद ज़्यादा और ज़्यादा you may need to be more aggressive, and though there is still a place there where you think about whether you want to do plasmapheresis. These patients may be at increased risk of pulmonary hemorrhages as well. Biopsy करके फिर choices क्या हैं? अगर बहुत patient sick है, there's no infection, so sodium withdrawal के साथ cyclophosphamide is still a very, very valid option in Pakistan. Of course, you have to, counsel fertility and infection na ho, lekin it is cost effective, it is very, it acts quickly, you're able to, wean off the steroids quicker, and of course work up if possible for rituximab. You can even combine the two together. I just want to add कि बच्चों में इतना कॉमन नहीं होता एंका एसोसिएटेड वैस्कुलाइटिस, बट होता भी है, और उनके अंदर भी पहले प्रॉब्ली फर्स्ट लाइन इज अगेन doing all of these, ruling out infections, pulsing. Cyclophosphamide has a real role in children because the disease is very, very active. और हमारे यहाँ तो आपको पता है affordability बहुत कम है. जहाँ पे हो तो mycophenolate और of course rituximab तो is an approved indication.
Thank you very much, madam. Well taken point. The compatible clinical picture is if it is there, positive PR3 is there or MPO ANCA is positive, then you should not wait for the biopsy. You should go for the treatment right from the beginning. And these cases should be managed at the experience centers. These are the guidelines which say, and our panelists also agree on that point. So we should not wait for the biopsy. We should start the treatment as early as possible. This is my question to Professor Dr. Ahmed Saeed Saab for the remission reduction in organ-threatening ANCA-associated vasculitis. All the international guidelines, including EULARS, ACR, KDIGO, and BSR, recommend glucocorticoids combined with either rituximab or cyclophosphamide. When would you prefer rituximab over cyclophosphamide or vice versa? And can we combine rituximab or cyclophosphamide too? So this is a question, sir.
Thank you for asking me to be part of this panel. I think there is a great discussion going on around the case. Let's put in this case in the context. I would like in this 40-year gentleman, methylprednisone, as Professor Sumaira has mentioned, anywhere between 500 to 1 gram per day for 3 days, along with the cyclophosphamide, because the mechanism of action of cyclophosphamide is like that it's going to be effective within 7 days, 7 to 10 days, and will like to get all the workup done for rituximab. There has been instances, especially when we extrapolate our experience from lupus nephritis, that you can combine both things together, rituximab and cyclophosphamide, especially in a setting of a very life-threatening and organ-threatening disease like our patient has, because he already has lost more than 50% of his renal functions, and he has a saddle nose, which means that he has organ-threatening disease going on for quite some time now. So this patient would require a rituximab, and rituximab workup requires some prerequisites as well, and there is issues of access. I'm glad to hear that it's available at few centers in the government hospital. This I have learned lately, that LGH is one center, but it's not widely available, and it is cost. Cost actually is a main factor. So cyclophosphamide should remain the first mainstay, IV cyclophosphamide along with methylprednisone. And if possible, add rituximab, withdraw cyclophosphamide. You don't need to give another cycle of cyclophosphamide or just one more cycle with the second dose of rituximab. Just stop cyclophosphamide, go ahead with rituximab, 375 milligram per meter square every week for 4 weeks, or you can use the other, which is not like the clinical trial dose, which is the RA dose of 1 gram, like 2 weekly, and then 500 milligram of maintenance from onwards for controlling the disease.
Thank you. Point has been well taken. So glucocorticoids and rituximab or cyclophosphamide, new onset ANCA-associated vasculitis, these are the guidelines with the consensus, all the 4 guidelines. Rituximab should be preferred in relapsing PR3 disease, fertility concerns, elderly and frail patients. Cyclophosphamide is still valuable when rituximab is unavailable or in very severe renal cases. Rituximab with cyclophosphamide combination for severe glomerulonephritis when serum creatinine is greater than 4 milligram per deciliter, or patient requires the hemodialysis. These are the indication for the combination. So my question about the glucocorticoids, which is the main question over here, and we have to discuss it a little bit more. International guidelines now advocate a rapid glucocorticoid taper and consider Avacopan as a glucocorticoid sparing agent, especially in patients at high risk of the steroid toxicity or with severe renal involvement. What is your preferred glucocorticoid dosing and tapering strategy, and what is the role of the Avacopan? Sir, I pass this question to Dr. Mateen, sir.
Assalamu alaikum. Thank you, Dr. Ali. Actually, the international guidelines, especially in the KDIGO guidelines, for the induction of this ANCA-associated vasculitis, you have to give the pulse therapy of the solamidol for 3 to 5 grams. That is for the 3 or 4 days. But the international guidelines also favor that the rapid tapering of the glucocorticoids because of having some side effects of the glucocorticoids. And in the trials where it was studied and you will rapid these glucocorticoids up to that of when initially you started with the 1 milligram per kg per day for the initially 2 to 3 months, and the rapid tapering, and you have to make this glucocorticoids up to 5 milligram per day up to that of the 6 months.
Sir, what is your practice? These are the guidelines which are saying we should reduce the dose. What is being practiced over here? Because we don't have the Avacopan right now.
Yes, we don't have the Avacopan. So for that of the glucocorticoid sparing, this is all actually depend upon the response of the your induction therapy of the either you will induct with the rituximab or the cyclophosphamide, and you will get the initial remission as early, so you can taper the steroids as early as possible. So after that you have to continue with your maintenance phase of this treatment of this ANCA-associated vasculitis with rituximab or the cyclophosphamide along with the low dose of the steroid as well. As we don't have any Avacopan here, in the trials which is studied that the Avacopan is more useful in the induction as well as the maintenance therapy for the glucocorticoid sparing agent. Thank you.
Thank you, sir. Sir, what is your take on that, sir? Dr. Ahmed.
I believe, yes, the steroids, we all know that these are double-edged swords, and the lesser the better it is. We do not want at the same time to undertreat our patients and do not like them to develop complications of long-term steroids. But in this setting, when you are dealing with an organ-threatening and life-threatening disease, yes, I agree that 1 milligram per kg is generally the rule, the standard of care. But once you have pulsed, you can rapidly taper. There is a trial which is a plexivas trial, so which has now given us enough evidence that we can have a rather rapid taper even without Avacopan. So it's plexivas is not talking about Avacopan. It is basically the trial which was looking at the role of plasma exchange and the rapid taper, prednisone versus the slow taper. So the slow taper arm, they were at the 6 months, they were still on 20 milligram of prednisone, starting with 1 milligram per kilogram. And in the other arm, so they were on 20 milligram by like 8 weeks, and by 3 months, they were on 10 milligram. This is what we have been practicing at our center. We generally start with either 0.75 milligram to 1 milligram per kilogram in patients who have life-threatening disease. We try to taper them by like 8 weeks to around 10 milligram. This is what we are doing, and this is what I would advocate.
Okay, you bring
but at the same time, we are using either cyclophosphamide or rituximab for induction. Without that, it's not going to happen. This disease is very remitting relapsing disease. If you would not institute steroid-sparing drugs, forget about Avacopan, which is not available here. I'm talking about the 2 options we have. So, and then you can think of tapering depending upon the patient's response. One thing again, the role of a biopsy is really very pivotal because it's going to give you prognostic value. Your patient who has already extensive disease, which is chronic and a lot of fibrosis, sclerosis already has happened. This patient is not going to respond. That patient is going to head towards end-stage renal disease, and you do not want to escalate treatment in that situation. So biopsy has a role.
Thank you. Ma'am, what will be the effect of this treatment on the sinonasal presentation or the part of the clinical presentation?
मैं सॉरी वापस पुराने सवाल पे जा रही हूँ. So just want to talk about in children what is recommended. So the latest guidelines जो lupus nephritis के लिए आई हैं वही, और उससे पहले जो एक induction therapy आई थी, I'm just applying it to ANCA vasculitis also because we don't have enough trials in children and बहुत ज़्यादा adult data ही हमने उसके ऊपर apply किया. So the induction therapy actually changed how fast we can taper steroids in children, and that was that you start pulsing them at 30 milligram per kg per day from 3 to 5 days, and for the first 6 months this pulse can be repeated weekly, say 2 weekly or monthly depending on the status of the child, while decreasing the daily dose right from the get-go to 20 milligrams a day. तो वो जो चीज़ थी कि 1 मिलीग्राम पर केजी के ऊपर, क्योंकि बच्चों के बहुत और इश्यूज होते हैं, ग्रोथ एंड कुशिंगॉइड एंड रिस्क ऑफ इन्फेक्शन, AVNs, सारा कुछ. That really changed how well these children responded, and this was combined either with induction with cyclophosphamide, और उन्होंने NIH प्रोटोकॉल यूज़ किया था. उसमें जो 1 ग्राम मीटर स्क्वायर मंथली आप देते हो, लेकिन आप उसमें यूरोलूपस ऐड कर सकते हो जो हम करते हैं फिर 500 मिलीग्राम एवरी 2 weeks, एंड यू कैन गिव दैट generally जैसे 3 महीने दिया, but you can extend it to 6 months depending on, of course fertility is a question and a big question, लेकिन बच्चे की जान बचेगी तो वहाँ तक पहुँचेंगे. And हमारे we know that our children behave more like Hispanics and Afro-Americans. They are very, very aggressive diseases in these children. And आपकी cyclophosphamide cost effective है and compliance ensure हो जाती है. अगर आप उनको mycophenolate पे डालते हैं, बहुत ज़्यादा experience है कि they will not either stop taking it because it's not, gut is not tolerating, or they cannot afford it. So you have to talk to the parents, but you need to ensure that the child. So this is a great way to do it, and इसके अलावा just, you can look up, but there are now shared guidelines as well, जो कि हर type of lupus nephritis का भी बताते हैं. वही चीज़ें फिर हम ANCA vasculitis में करते हैं apply. So the idea is that you pulse 30 milligram per kg in children, and you can repeat it weekly or monthly for the first 6 months, and decrease the dose of oral prednisone to 20 from the get-go. The idea is, इस वक्त के आपने for clinical remission, you want the steroids to come down to 0.15 milligram per kg within 6 months, 0.10 for remission, and low disease activity 0.15 milligram within 6 months. और अगर नहीं हो रही तो फिर आप अपनी treatment को accelerate करें. और बच्चों में भी cyclophosphamide, those who can afford it, rituximab, combining rituximab and cyclophosphamide, and of course mycophenolate does wonders as well. So,
thank you very much.
ये मैंने सिर्फ add करना था डॉक्टर साहब के वजह.
I just want to add that since we are doing induction with very high immunosuppressive agents, so as Dr. Smara has very rightly pointed out, that we are living in a country which is infection dominant or prone or whatever you call it, but we have a lot of infections here, and we should screen for the infection before starting the induction, but then again it is wastage of time, but you at least send the tests. I don't know if there is any recommendation, at least I don't do it, start the antibiotic along with it. So, but one scenario needs to be addressed because it is itself life-threatening in ANCA-associated vasculitis, and that is pneumocystic cranii infection. And that prophylaxis needs to be started straight away, even if we don't have anything available in terms of tests. So, yes, as far as steroids are concerned in adult population, my personal practice is that I would like to stop it as early as possible, or at least reduce it to a minimum dose as early as possible, but not for at least first 2 weeks after the pulse, or rituximab or the cyclo is all given. So after that, I would like to taper it off and reduce it to as low as possible by 8 weeks or maybe maximum 12 weeks. As far as steroid sparing agents are concerned, we don't have the luxury of those expensive drugs that you are mentioning, but we are lucky that we have mycophenolate mofetil with us, which is a steroid sparing agent in itself. We have methotrexate, which is steroid sparing agent in itself. We have azathioprine, which is steroid sparing agent in itself. So we have other options which we should look into instead of looking into very specific treatment options which are not available, and which are, even if they were available, they are not in reach of every person, because even rituximab is not in reach of every person. So as Dr. Smire said, that sometimes we only have to resort to steroids. So that steroid is a tricky thing, as Dr. MSC said, this is double-edged sword. So it is your expertise and your knowledge and your sharp eyes that should recognize when and where to taper it, and it should be tailored in every patient. You cannot generalize. These guidelines are guidelines. These are not rules. They cannot be applicable to everyone. It is not that no right turn will cause a challan every time or an accident every time. You still have a possibility that if you take the right turn, you may go to a little left and save the patient. So in terms of treating the patient, we should follow the guidelines as much as possible, because they are made with the intention that the patient should get the most benefit without least of the side effects and least of the cost. But they are not always possible to follow. So I think we should tailor from patient to patient how we should approach. Yes, sinonasal disease control is important, but then again, as initially Professor Dr. Hafiz Mahmood from Aga Khan said, that comorbidity screening. So we should have a multidisciplinary approach, and we should involve the ENT surgeon, nephrologist, everybody, so that we can give the best out of what is in our pocket to the patient.
Thank you very much, sir. Your point has been well taken. It depends on the patient condition, and the patient-to-patient variation will be there for the glucocorticoids dosages. My question, but I need the crisp answer from Dr. Hafiz Saab. In this particular patient with rising creatinine, would you recommend Plex?
Before answering this question, I just quickly want to clarify a couple of points. First of all, rituximab is not fit for all. The patients who present with more severe renal dysfunction, like creatinine more than 4, we have no data for rituximab. So we should be opting for cyclophosphamide from the very beginning. Number 2, now we have sufficient evidence available of low-dose glucocorticoids also. Low-VAS trial tells us that even 0.5 milligram per kg per day from the very start is an acceptable option instead of our previous routine of 1 milligram per kg. And PEXI-VAS trial has given us another guideline that we could taper more quickly within a month to 2 months to go to the smaller dose. Coming to this question of Plex, the patient whose renal function is quickly worsening and also has pulmonary hemorrhage, this is a combination where KDIGO guidelines tell us to give plasma exchange. Simply just for pulmonary hemorrhage, ACR guidelines also do not recommend for this. So in this patient, if he develops some other organ involvement like having pulmonary hemorrhage and then creatinine is rising, then Plex is an option. And of course, we should be very vigilant about its side effects in terms of infection.
One thing I would like to add over here is that there is an overlap between ANCA vasculitis, GPA and anti-GBM. And if
Right.
there is an anti-GBM, so then obviously you would like to go for PLEX, and that would be a
Right.
modality for that.
Very rightly said that if it is a mixed disease having ANCA-associated vasculitis and anti-GBM, then PLEX is the option.
Okay, sir. Thank you very much, sir. So this is a consensus by our panelists. Consider only if serum creatinine is 3.4 milligram. These are the guidelines as well as our practice over here. Rapidly rising creatinine due to active glomerulonephritis or diffuse alveolar hemorrhage with hypoxemia. So we also follow the same guidelines over here. Our practice matches with theirs. Mandatory in anti-GBM overlap, but the Pexivas showed no broad benefit of the Plex in ANCA-associated vasculitis. So it is conditional, basically.
My question from nephrology panel is that biopsy, of course, is very important, and the presence of crescents show active disease, and presence of fibrosis, on the other hand, shows slightly less active or no active disease. But I was just wondering if we have a clinical picture in which the patient is deteriorating and we have performed the biopsy, and biopsy later on comes out with a fibrotic picture, do we stop our treatment or we just carry on with what we are doing?
It is recommended by the guidelines that the results of biopsy should not hamper you from carrying on the treatment. Even with some more advanced changes, continuing immunosuppression therapy has shown the benefits.
So in this context, I was just wondering, as a lay person, that should we really need biopsy? Should we really need biopsy?
Rebiopsy after certain time.
Should we really need biopsy?
In what case?
In this case, because if it is showing fibrosis, we are carrying on. If it is showing crescents, we are carrying on. So what is the fun of getting biopsy?
Sir, I take up your question. Actually, before starting the treatment, if we should go for biopsy and patient has cellular crescents. And I will add that more of our respected colleagues have contributed their experiences that the Pexivas Plex along with the steroid plasma exchange along with the low doses tapering steroids. We should actually, in such cases, if patient not having alveolar hemorrhages and we found patient has more than 50% cellular crescents, along with all the cyclophosphamide, rituximab, prednisolone, we should start given 60 ml per liter, 5 to 7 sessions of plasma exchanges as well, first thing. And even if we have fibrocellular crescents, we should continue this treatment. Yes, your question was that when we should go for the second biopsy. If initially there was activity index was predominant and chronicity index was not as at the first time, and patient has still dialysis dependent, yes, you are right, we should go for the second biopsy in 4 to 6 weeks.
Thank you, sir. Thank you, sir. We have to conclude it because time is up, and I require your answers very quickly and very concisely, please, so that we can end up on time. After successful induction, what is your recommended maintenance strategy for this patient? Just quick answer, please.
So you, for the maintenance strategy, either you can continue with the rituximab or you can continue with that of the cyclophosphamide as well. In the oral treatment, you can start with that of the azathioprine. So both are the trials available. Either if you induct the patient with the cyclophosphamide, you can switch over to the maintenance therapy with the rituximab, or if you induct the patient with the rituximab, you can continue with the maintenance therapy of the rituximab as well. So for that of the maintenance, oral treatment, mycophenol, azathioprine, you can continue with up to that of, it all depends upon the monitoring of that the disease. If the patient have achieved the full remission, you can switch over to that of the azathioprine as well. Thank you.
We will continue with the mandatory trials actually
Okay,
for
sir.
the maintenance.
जी मैम,
जी, I
please.
just want to say कि हमारा experience हुआ है with azathioprine in nephritis, whether it is lupus or ANCA. I don't know whether it's genetic or what, लेकिन हमारा ज़्यादा एक बेहतर mycophenolate. So maintenance अगर oral पे जाना है तो probably mycophenolate. If they can afford maintenance with rituximab, तो वो आप every 6 months.
And sir, ma'am, what about the background dose of the steroids?
स्टेरॉइड तो आपको टेपर करने हैं
वो 5 milligram
और लेस एक्चुअली. अब तो कहते हैं कि लेस देन 3 mg, और इफ यू कैन कम टू जीरो ideally, because
Yes.
you're increasing risk of infections and lot of other comorbidities.
Yes, thank you very much, ma'am. So our practice also matches with the international guidelines. So monitoring for the remission and relapse, how frequently and with what parameters would you monitor this patient for remission and early relapse? Ji sir, please. Sir, Tafazul.
The frequency is initially from 1 to 3 months, or if possible earlier, because it's a life-threatening disease. So, but at least minimum 1 month, and if a patient is a little bit stable, then 3 months. As far as the parameters are concerned, they are again the clinical scenario. It's not ANCA. Please note that it's not ANCA. ANCA alone is not sufficient to give you an insight into what is going on. It is a helpful tool, but the clinical scenario, for example, in granulomatous polyangiitis, GPA, the ENT examination, the ENT surgeon's perspective, how the disease has settled, the urine complete examination, how RBCs have settled, how creatinine is settling, how proteinuria is settling, all these things, and blood pressure, all these things in addition to the ANCA taken together should make the parameters complete, and let us decide that if we should reduce the treatment. And चेंज क्यों कर दिया यार, पीछे जाएं, वापस जाएं, ठीक है ना. रिमिशन हुई है कि नहीं? यस, पेशेंट रिमिशन अभी नहीं हुई है, बिकॉज वी डोंट नो दैट. We are not inside the body. We don't know. We are only monitoring the symptoms. We are only monitoring the maybe ESR and CRP. We don't know. So we will continue. We will remain aggressive. We will remain on toes. We will not stop, because this is something which can be the reason for a very valuable family member's loss. So please think about that as well. So you have to be. If they don't have the monetary funds available to them, there are hospitals now. They were not 10 to 15 years ago from. But there are hospitals now where they can go and get their disease monitored. So early relapse, whenever there is early relapse, you just increase the dose of the steroids, you just increase the dose of the maintenance disease-modifying agent, whichever you are giving, and then keep on looking. Call an early follow-up, maybe in a month's time instead of 3. And if it is a severe relapse, then you have to go for, unfortunately, reinduction. And reinduction is not always going to be with rituximab, cyclophosphamide, because most of these patients may be females and they have fertility issues. You can't give steroids to all diabetics with very heavy monitoring, very vigilant monitoring. You can't give steroids because of previous steroid exposure and lot of osteoporosis and whatnot. So, you have to be very careful when you are reinducting. So when you are reinducting, of course, rituximab is the best choice, because it decreases the chances of exposure to more toxic drugs. But then it is sometimes not possible to give. As I said earlier, you have to tailor it. You cannot give cyclophosphamide over and over again because the cumulative effect of cyclophosphamide is going to affect the fertility. It is going to cause biocytopenias or whatnot. So, and risk of infection, it will also increase the risk of infection. So, that reinduction is going to be a big question mark in my mind when I'm doing it because I have to be very, very careful.
Okay, sir, if the patient develops a relapse of the disease, what will be the dose of the steroids? You would go for the high dosages again, or do you practice something else? My question is with Dr. Hafiz. Thank you, sir.
For relapse, our practice is to increase the dose of steroids from the before, because we can give cyclophosphamide in the same dose, but steroids should be enhanced maybe 50% or more. That is for the relapse.
Okay, sir. Sir, Dr. Mateen, if you want to add.
Depends upon the monitoring of your relapse as well. If you are having a high titer of the PR3 and you will get still the active sediments in the urine on the urine complete examination, then it all depends. The relapse, you have to increase the dose of the steroids, or either you can start with again induction with the cyclophosphamide plus as well rituximab. If the patient initially having an induction with that of the cyclophosphamide, so you have to change the cyclophosphamide to rituximab. And if the patient have initial induction with the rituximab, you have to change the rituximab to the cyclophosphamide if the patient relapses.
Sir Ahmed, if you want to speak on it.
I would agree with our nephrology colleagues, Professor Mateen. So this should be the practice. If your patient has failed rituximab, the second induction should be with cyclophosphamide and vice versa.
Okay, sir. Is there a role of combination of
The combination, the role is over
rituximab
there.
plus cyclo?
Yes, that can be done, but risk of infections long term should be kept in mind, because we know that that's going to add more burden to infection.
Okay, sir. Actually, sir, I want to extend this question for our audience. If you want to add, sir.
I just want to add one thing, that combining cyclophosphamide with rituximab is that you are putting the patient on an atom bomb. So you should avoid it as much as possible.
Actually, I am...
Reinduction के लिए कह रहे हैं ना कि दोनों चीज़ें ना combine कर, एक अगर fail किया तो दूसरे पे चले जाए, rather than...
Okay, sir, last but not least, if someone of us has the experience of using a Vacopan, or if you know about it, especially Sir Hafiz, if you have used this medicine?
So far, this is not available to us. It's like a $20,000 per month treatment. So we don't have experience, but from the trials and guidelines, we know that for more severe renal dysfunction, Avacopan has the edge. And improvement in serum creatinine also greatest with Avacopan compared to steroids. But let's hope when it gets cheaper and we are able to use them for our patients.
Thank you very much, all the panelists, for giving us insight into this particular topic of autoimmune nephritis. We have just touched ANCA-associated vasculitis. I would like to have you again, inshallah, for lupus and other diseases. I wanted to have some questions on lupus as well, but I haven't it left with time.
ज़बरदस्ती उसके ऊपर बोल लिया.
नहीं, ma'am, we had the plan, but thank you very much, sir, and rheumatologist panel as well. So kind of you.
Thank you so much.
Thank you for having us.
Okay, we have the honor of having Professor Masood Sadiq Sahab, who is the Vice Chancellor of the University of Child Health Sciences. I will request him to come to the stage and distribute the certificates of these panelists as well as the first session presenters. Sir, please.
Professor Dr. Hafiz Ijaz Ahmed. Once again, for Professor Dr. Hafiz Ijaz Ahmed, a big round of applause, everyone. Professor Dr. Ibad Rehman. Dr. Mateen Akram, Professor Dr. Muhammad Ahmed Saeed, Professor Dr. Sumaira Raja, Professor Dr. Tafazul Haq Mahmood, and our moderator for this panel, Dr. Ali Rukh Peerzada. And for the speakers of our first session, Dr. Maisam Afzal. Dr. Babar Salim. Dr. Hafiz Muhammad Mahmood Riaz.